Thank you. Good morning, everybody. So, first of all, thanks to the NGR for this invitation to present this work on the inequalities in provision of hip and knee replacement for in England. So, this work has been conducted by the University of Bristol, Sheffield, and the University of York. So, as you all know, fairness and access to healthcare is one of the founding principles of the NHS. However, around 20 years ago, my colleague and co-author, Professor Andrew Dutch, shows that huge inequalities in terms of age, gender, and social class, with lower provision for those in the most deprived areas compared to the relative needs. So we decided to use the data from 2007 to 2017 to focus on the primary hip and knee replacement performed for all age among patients aged 50 years old or older, patients living in England and also operating in England. And we also linked those data to the data from the Office for National Statistics to get the number of people living in England within the same age and gender groups, as well as the index of multi-deprivations, which is an indicator of social deprivation by social and by geographical areas. So we look at the rate of provision per 10,000 persons, map those rates by geographical location and specifically the clinical commissioning groups. And we look at age, gender, and the index of multiple deprivations from the most deprived groups to the least deprived groups. So we use appropriate statistical techniques accounting for the clustering of the data by age and gender, but also we use geographical information system modeling to plot and compare those rates by regions. So in total, we had over 670,000 primary total hip replacement and over 830,000 primary knee replacements. And as a whole, between 2007 and 2017, we found an increase in the provision of hip and knee replacement. However, this overall increase is hiding a lot of disparity. So today I only have time to present our result on social inequalities, but I will point you to the paper if you're interested in the gender and age inequalities. So here are the results for total hip replacements. So on the left-hand side, you have the rates and the rate provisions. So the lower lines represent the IMD ones, the most deprived people. The highest line represents the least deprived people. And as you can see, the inequalities that were observed in 2007 are still evident in 2017. And so what is very interesting for the provision of hip replacement is that from 2007 to 2012, the difference were more or less equivalent. So you can see that on the right hand side, if you compare a black line to our reference, the red line is the least deprived group, you found that the rates were more or less flat up to 2012. But from 2012 to 2017, then you can see that the curves decrease. So in other words, the relative difference between all social groups and the least deprived ones increase. And those differences were evident in both the private and public sector. For the total knee replacement, we found more or less the same pictures. So we found substantial inequalities, but those inequalities decreased from 2007 to 2012, as shown on the right-hand side. But from 2012 to 2017, we found increase in those inequalities with lower provisions for those in the most deprived groups compared to those in the least deprived groups. Those inequalities, however, were only apparent in the private sector. So now if we look at the geographical inequalities, so the top row represents the total hip replacement, the bottom row represents the total knee replacement in 2007, 12, and 17. The darker an area, the higher the provisions. And as you can see over time, the areas become darker, so meaning that the provision increase. However, we found substantial geographical inequalities. So in 2017, for EP, we had a five-fold relative difference between the least provided area and the most provided areas. And for me, we found a threefold difference between the least and most provided areas. To conclude, we found that the large inequalities previously reported and found in 2007 were still apparent in 2017 for total hip and knee replacements. And even if the absolute number of procedures have increased over time and the geographical variation has decreased, we still found substantial inequalities. So which means that the current strategy in the NHS to deliver increased case numbers and tackling the inequalities successfully, that's something that needs to be done in the orthopedic community, but also with the NHS, trying to alleviate those inequalities. So it's a very quick presentation for all those who are interested in it. I invite you to read our paper published in PLOS Medicine. And I also invite you to stay tuned to this topic because we are on the edge of publishing the sequel of this work, looking at the inequalities in the outcome of primary arthroplasty. What people are resettled primary is the outcomes different according to your specialties. So in this room you have Professor Rangan and Professor Whitehouse and myself. So if you want to discuss further, please approach us. Thank you very much.